My name is Dr. Sophia Ahmed, and I'm the initiative lead for the CV&Me Women's Cardiovascular Health Program at the Libin Cardiovascular Institute here at the University of Calgary. I'm very fortunate to be your host for this evening, and I welcome you all. Thank you very much, especially with the weather, the way it is outside. I know we're all at home on Zoom, but very much appreciate your time this evening. So before we begin, I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta. The city of Calgary is also home to the Métis Nation of Alberta Region 3. So just before we start, I just have a few housekeeping things to let people know. We have started now. We will finish the presentation. After I give the introduction, Dr. McRae we're very fortunate, will give his presentation, followed by a question and answer period. We will finish right at 7 o'clock. So just to let you know how things will go this evening. As a few other housekeeping reminders, please do not feel pressured to enable your camera. We really want people to just sit back and enjoy this webinar. So whatever works for you is wonderful. Please do note that the presentation portion of this webinar will be recorded and published online. So if you miss something, don't worry, you'll be able to see it in the next day or two on YouTube, and we will send you that link. And please be mindful of your privacy when asking questions and sharing personal details. This evening, you all know, and as the main event, we will be looking forward to hearing a phenomenal presentation by Dr. Andrew McRae, one of our emergency room physicians and clinician scientists here at the University of Calgary in the Libin Cardiovascular Institute. As I said, followed by a question and answer period. We encourage you to type any of your questions into the chat box. We will not be enabling the mute buttons or unmute, I should say. So please type your questions in the chat box. Anytime during the presentation, we'll answer them, or rather Dr. McRae will answer them at the end. If there are questions that you do not feel comfortable asking publicly, please type them to me privately in the chat box, and I will ask them privately, or I will ask them on your behalf while keeping you anonymous. So just moving on to tell you a little bit about the Libin Cardiovascular Institute before we move on to Dr. McRae's presentation. In Canada, unfortunately, somebody dies every 7 minutes from an illness related to a cardiovascular event, costing the economy more than $25 billion every year. Currently, 9 out of 10 adult Canadians have at least one cardiovascular risk factor, and 50,000 people are diagnosed every year with heart failure. And it really doesn't need to be this way. So the Libin Cardiovascular Institute at the University of Calgary is committed to changing the future of cardiovascular research. Our coalition of clinicians, staff, researchers, and trainees works collaboratively to advance prevention and treatment of cardiovascular disease. So just moving on, we'll just tell you briefly about some of the programs at the Libin Cardiovascular Institute. We have a few. First one is P2, Person to Population Cardiovascular Research Collaborative, which is a multidisciplinary team, meaning physicians, nurses, physiotherapists, across the spectrum, pharmacists, teams of researchers and clinicians who are truly committed to improving cardiovascular health in Alberta at the individual and population level. Next slide, please. The Libin Data Initiative is designed to improve patient outcomes by integrating cardiovascular data for use in clinical decision-making and research. This initiative strives to make the data easier for all researchers to access and use while building collaborations to build better resources for patients and clinicians. Next slide, please. The Stevenson Cardiac Imaging Center is one of the leading clinical research and teaching facilities in the field of cardiovascular MRI, or magnetic research imaging, truly in Canada and in the world. Next slide, please. And then lastly, the CV&Me, CV being short for cardiovascular, Women's Cardiovascular Health Research Initiative. And truly, The goal of this wide group of clinicians, researchers, scientists, trainees across the spectrum of cardiovascular health are here together to transform the future of women's cardiovascular health through health research, training, and care. So with that, I will move on to our main presentation with Dr. McRae. So we're very excited to introduce Dr. Andrew McRae as this evening's keynote speaker. He is an emergency room specialist practicing at the Foothills Medical Center and Rocky View General Hospital. He has a research appointment at the University of Calgary and is a member of the Libin Cardiovascular Institute. His research work focuses on developing personalized diagnostic strategies for emergency department patients with suspected heart disease to help ensure that the right patient gets the right care at the right time. So without further ado, welcome. Thank you very much, Dr. McRae.
Thanks very much, Dr. Ahmed, for that kind of introduction and for the kind invitation to talk with all of you today. I hope everyone's staying safe and warm as we start to transition to winter in earnest. This is a really timely topic because we absolutely do see an increase in the number of cardiac emergencies and the number of cardiac deaths in the winter season. We often think of this as an increase in heart attacks from shoveling snow, but this isn't just a Canadian phenomenon. This winter increase in heart events is seen worldwide. It's been documented in Spain, the UK, lots of other places that don't get a lot of snow. Plus, when you consider that heart disease is a problem that develops over years and even decades, we have to wonder just what is it about winter that causes this spike in cardiac events? And there's a lot at play. The holidays are a happy time for a lot of people, but they can also be a really stressful time, and that can certainly be a contributing factor. Changes in our diet in the winter may play a role to a certain degree, especially with an increase in fat and salt and alcohol over the holidays. And for people who already have heart disease or kidney disease, this may certainly play a small role in increasing the number of heart events. Changes in activity are probably a factor, whether it's shoveling snow or playing beer league hockey after not being active the rest of the year. We might not have been doing a great job of preparing our bodies for the kind of brief, intense activity that's much more common in the winter. And finally, probably the biggest contributor to this increase in cardiovascular emergencies in winter is the seasonal changes and the seasonal increases in other illnesses that spike over the winter, like the flu and other respiratory viruses that put an added strain on our cardiovascular systems, and they're especially dangerous in patients with pre-existing heart disease. So I wanted to use my time tonight to try to answer some questions that you might have about cardiac emergencies and talk about things you should know in winter and year-round to keep your heart healthy and safe. I'm going to talk about when you should come to the emergency department and what symptoms should worry you and prompt you to think about coming to the emergency department. And once you're there, I want you to have some tips for communicating with emergency department staff to try to help you get the care that you need. And things that you might need to know, tips for staying healthy that will keep us from having to meet at my place of work. So there's been a lot of public messaging out there around things that should prompt you to come to the emergency department. And unfortunately, not all of it agrees. The Heart and Stroke Foundation has done a great job of advertising the kind of symptoms that might indicate someone's having a heart attack or a stroke. They've also recently put out more information on heart symptoms that may be different in women compared to men. But on the other hand, there's also been some messaging over the years from government and health agencies that have really good intentions of trying to minimize emergency department crowding, but might also have the unintended consequence of causing some people with a serious problem to second guess whether they should come to the emergency department. So I'm going to try to be as plain and as clear as I can be. If you're experiencing a sudden symptom that worries you, you should come to the emergency department. Don't worry about contributing to crowding. It generally doesn't take much in terms of resources to evaluate a patient and be reasonably confident that there isn't anything serious going on. So I'd much rather see somebody in the emergency department and be able to reassure them that there likely isn't a serious cause for their symptoms than hear about any patient with a serious problem who waited too long at home before coming to the hospital and potentially had a bad outcome. Plus, many of the problems that we worry about have a time dependency in that patients have better outcomes if they seek care sooner. So it's best to come to the emergency department early if you're worried. So that statement begs the question, when should you be worried? I'm going to talk a little bit about symptoms that should worry you, but it's not really going to be possible to say definitively if and when you should come to the hospital. Part of the challenge of emergency medicine is that when we meet a patient for the first time and listen to their symptoms, we need to consider all possible causes for their symptoms and not just the heart. So if I told you that you had a pain in your chest for 3 days straight, that it's unlikely to be a heart attack, that's absolutely true. But it might still be something dangerous going on with your lungs or your stomach or your pancreas. So it's not going to be possible for me to tell you specifically when you should and shouldn't come to the emergency department. But I want to take some time to talk about the symptoms that are most often associated with a heart attack and symptoms that should cause you to raise some alarm bells for you. Most patients having a heart attack experience some sort of chest discomfort. Indeed, between 75 and 90% of both men and women experience chest discomfort with a heart attack. Most commonly, it's described as a pressure or a heaviness or a tightness or a burning, but some people either experience or describe it differently. In medical school, it's drilled into us that heart attacks can cause symptoms anywhere between the belly button and the jaw. Sometimes it spreads through between the shoulder blades, sometimes up to the neck, shoulders, and upper arms. Sometimes the discomfort in these other locations is even more prominent than the discomfort in your chest. So it's really important to be aware and tell your doctor if there's any discomfort in your chest or if it's just confined to those other locations. The other point I want to raise is that the timing of your discomfort is almost as important and possibly even more important than the feeling of the symptoms itself. Pain from coronary disease like angina or heart attack usually lasts several minutes to an hour or more. But other types of pain that lasts only seconds, or pain with deep breathing, or pain that lasts for days or longer, can help point us toward other causes. And so being really clear about the timing of your pain is really important for getting us started in the right direction in terms of where to look for the cause of your symptoms. The other important thing about timing is that when we're trying to diagnose a heart attack with blood tests, we time those blood tests to the maximal severity of a patient's symptoms, and that increases the accuracy of those blood tests. And so it's really important to help us be as accurate as we can with our tests to be as precise as possible about the timing of people's symptoms. And I'll talk to you a bit later about how to best communicate more about your symptoms to your care team. I want to talk a bit about the differences in heart attack symptoms that men and women may experience. This graphic is from a cardiology clinic in the United States. And I like it because it shows a lot of the different symptoms that men and women can experience with a heart attack. So back and neck pain, jaw pain, indigestion, extreme fatigue, cold sweats. What I think this graphic could do a bit better is that the overlapping purple area could probably be bigger. It's worth emphasizing again that between 75 and 90% of patients, whether they're men or women, will have some sort of discomfort in their chest with a heart attack. The thing is that in some patients, chest pain might be present, but it might not be the most prominent or the most distressing symptom. And we often focus on the most prominent symptom or the most distressing symptom. And that miscommunication around the presence or absence of chest discomfort can sometimes lead to delayed or misdiagnoses of heart attacks. So it's important to be aware that heart attacks can cause a range of symptoms like neck pain and jaw pain and indigestion and lightheadedness. And those symptoms should be taken seriously. But it's also important to report any chest discomfort that you might be experiencing if you come to the emergency department. I want to talk about other symptoms that people might experience, either in addition to or instead of chest discomfort. Shortness of breath is an important one, and it's breathing difficulty that often gets emergency department staff the most worried. Lots of serious problems cause shortness of breath. And if you start to notice over time, gradually, that you're getting out of breath more easily, that you're not able to walk as far as you used to or climb as many stairs as you could before without getting short of breath, that's something that your family doctor needs to know about and needs to start looking into. But if your shortness of breath gets worse quickly, like over days, or if you're suddenly short of breath, especially to the point where you're out of breath just talking or walking across the room, that needs to get checked out quickly. I'd like to unpack the terms lightheadedness and fatigue a little bit. When we think of fatigue as a symptom of a heart attack, we're not necessarily talking about tiredness that's been creeping over time, like we're burning the candle at both ends or feeling like we're out of energy. Those can be symptoms of other serious things like thyroid disease or anemia, so they shouldn't be ignored. But the sensation that comes with a heart attack is fairly sudden. It's an overwhelming sensation, a feeling like you might actually pass out. And so sudden lightheadedness or fatigue, especially with any chest discomfort or breathing symptoms, shouldn't be ignored and should be checked out quickly. People having heart attacks often experience nausea, heartburn, or indigestion. And for patients who've had these symptoms before in a well-established pattern, that might not be cause for concern. But sudden symptoms, especially ones that you haven't experienced before or that are worse than usual or associated with other things like shortness of breath or lightheadedness, should also be taken seriously and should be checked out quickly. You might wonder, why does it matter whether men and women experience heart attacks differently and describe symptoms differently? And it's because it makes an impact on their outcomes. Women often come to the hospital or call 911 later after the onset of their symptoms, and that can decrease the potential benefit of time-sensitive treatments like emergency angioplasty. If symptoms are described differently or emphasized differently or underplayed, or if a doctor misattributes symptoms to something else, that can lead to missed or delayed diagnoses. All of these things can lead to worse outcomes if heart attacks aren't recognized quickly. So my take-home message about when to come to the emergency department is to come to the emergency department sooner if you're worried, and make sure you describe all of your symptoms really clearly and specifically. I want to talk a bit more about why it's important that patients and doctors understand each other when it comes to describing symptoms. A healthcare encounter can get mapped out like this. It starts with an information exchange between a patient and a healthcare provider. What symptoms have you been experiencing and when? The examination, like listening to the heart and lungs, sometimes add information, and often, but not always, tests can help us get to the right diagnosis. But getting to the right diagnosis is a lot like taking a road trip without a GPS. And the key to getting to the right place quickly is having the right directions right from the start. And that's what good communication between patients and doctors does. It gets us started in the right direction quickly. So I'd like to share some tips when describing your symptoms so that you can, to borrow a phrase, help me help you. Some doctors are better than others at helping patients or coaching patients to describe their symptoms and getting the information that they need from their patients. So it's important to try to be as specific as possible about what you're experiencing. Be as descriptive as you can. One challenge is that different words like numbness or tightness can mean different things to different people. So feel free to use comparisons so that we know exactly what you mean. So for example, say things like, it feels sharp like a knife, as opposed to just saying it feels sharp, because then we might not always know, well, do they mean sharp like a knife, or does it just mean that their chest hurts really badly? And so those kind of descriptives and comparisons are really, really helpful. And as I mentioned before, another important thing to emphasize is that the timing of symptoms is also really crucial. So when did symptoms start? How long did they last for? What were you doing when the symptoms started, or what brought it on? Does anything make it better? Does it make it worse? Timing can be an important clue as to the source of the symptoms. And like I mentioned before, we time a lot of our tests in relation to patients' symptoms. So the more precise we are and patients are or can be about timing, the more accurate our tests will be at the hospital. The other thing that I want to encourage people to do is to tell us what you're afraid about. So at the end of your encounter in the emergency department, especially if we haven't found anything serious and we think we might be able to get you on your way home from the emergency department, what we'll do is we'll try to wrap up with the information that we've collected from you, as well as the information that we've gathered from the tests that we perform, and try to put all the pieces together. And so it really helps us knowing what you're worried about, so that we can put your mind at ease and address all of your concerns. So please absolutely do tell us upfront what you're worried about, so that we can help put your mind at ease, especially if we're able to send you home from the emergency department. Some other tips that are important to share. We're fortunate in Alberta to have a really great electronic medical record that keeps a pretty up-to-date medication list. But if you're from out of province, or if you're traveling, or if you happen to the emergency department on one of our bad days where our IT systems are down, we might not have access to your medical records. So bringing either your medications or a list of your medications is extraordinarily helpful. And finally, I want to say a word about the importance of family. We'll talk about this a little bit later when it comes to our current COVID situation. But it's nice to have a loved one in the emergency department, or at least have someone who's easily contacted, so that we can get corroborating information and also provide some emotional support to patients in the emergency department. And so in normal times, it's really great to have family members in the emergency department with you. I want to move away from heart disease for a minute and talk about the elephant in the room, or the elephant in the emergency room, as it were, and that's COVID-19. We're committed to doing everything we can to keep patients safe. So we're doing things like physical distancing in the waiting room. We're making more use of private care spaces. We're changing the way that we move patients around in the department. And that's really good for protecting people, but some of these changes and the stresses on the system from the pandemic, things may move more slowly from time to time. But one thing we're not doing is cutting corners on the care that we provide, and we want to see you if you're worried. Things will work a little bit differently in terms of how we interact with family members. So as of yesterday, in fact, all Alberta emergency departments and all Alberta hospitals are limiting visitors. The current rules for emergency departments are that a patient, if necessary, can have one essential support person, like a family member. And this is important for seniors with cognitive impairment, for example. So one essential support person can be allowed in the emergency department if they're necessary for the patient's care. Up to 2 people will be allowed in for end-of-life care. But beyond that, we're unfortunately limited to phone contact. And this is really hard on patients. It's hard on families, and it's hard on staff, because involving families is a critical part of patient care. But ultimately, we're prioritizing the safety of the healthcare system, and unfortunately, we're having to limit the access to hospitals for family members. We'd like to see this pandemic over as soon as possible, so we can all get back to business as usual. So especially as case counts rise in the province, please, please, please limit non-essential contacts outside of your home and in your immediate family. And when you are outside the home, please adhere to physical distancing, wearing masks, and washing your hands often. I'd like to start to wind down and move toward the last section of the talk by sharing some tips to try to keep yourself and your heart healthy over the holidays. And it's hard to reduce your stress, but I encourage people to reflect on your plans for the holiday season and think really hard whether something's worth the stress that it's going to cause you, or if there's an alternative way of doing things that might actually be easier on your mental health and stress levels. Related to that, please enjoy substances in moderation for both of your heart and your mind and the rest of your body. It's important to stay active all year round so that your body is trained and prepared for things like beer league hockey and snow shoveling season. It's also a good idea to see your family doctor before the holidays if you have any ongoing health problems. Make sure that you have prescription refills to get through the holidays, because getting a refill in the middle of the holidays can be a challenge sometimes. As I mentioned before, there's absolutely an association between flu season and cardiac events. and it's especially dangerous in patients with underlying heart disease. So please do get a flu shot to reduce your risk of getting influenza, and that does go a long way to reducing your overall cardiovascular risk in the winter. It's never too late to take a CPR course, and if you ever had a loved one collapse, you'll certainly be glad that you did. And finally, we're still seeing patients who have car crashes, broken hips, broken wrists, and other body parts. So please do drive and walk carefully this winter. So doing all those things will help us do the best that we can for you. But there's lots of work that's still to be done to make emergency cardiac care even better. And I wanted to take just a few minutes to talk about some of the work that our team is doing. The focus of our team's work is to make us even more accurate than we already are in diagnosing heart disease in the emergency department. We know that the blood tests that we use to diagnose heart attacks aren't as accurate in patients with kidney disease. So we're working on developing strategies to improve the accuracy of those tests for patients with kidney disease and to develop more personalized risk prediction tools for identifying heart disease in the emergency department. We also care very much about what happens after a patient is tested in the emergency department and goes home. We know that the risk of a serious event after being discharged from the emergency department is extraordinarily small, but there still are some patients who might benefit from additional testing or specialist consultation after they leave the emergency department. And our team's work is to more accurately identify who those patients are, who may be at risk of heart events, who might need closer follow-up. And in other words, the goal of our research team is to get the right patient, the right care at the right time. And we're grateful to the Libin Institute for past and future support of this work. So to close, I wanted to emphasize the points that I made before. It's important to be aware of the symptoms of heart attacks. Whether for both men and women, chest pain is a very important symptom. It might just not be the most prominent symptom. And so it's also important to be aware of the other sensations that heart attacks might cause, like jaw pain, arm pain, shortness of breath, sudden fatigue and lightheadedness, and indigestion. And if you're aware of any of these symptoms, if you're experiencing any of these symptoms, come to the emergency department if you're worried. It's really far better to come to the emergency department early and get checked out than to potentially have a delayed diagnosis and worse outcome. And so we would much rather see people early on in their symptoms than later on. Help us help you with clear descriptions of your symptoms, and so that we can get started on the road to figuring out the cause of your symptoms as quickly as we can. And over the holiday season, be happy, be healthy, and stay safe. And so with that, I'd like to open up to any questions and discussions that people might have.
So thank you very much, Dr. McRae. That was an absolutely fantastic presentation. We'd like to move on right now to the question and answer period of the event. So if anybody has any questions, if you could type them into the chat box, and we'll answer them as much as we can in the order in which we receive them. As I said before, if you have a question that you don't feel very comfortable asking publicly, just send it to me privately. I'm, as you can see, Sophia Ahmed, and I will ask it anonymously on your behalf. But just to get things started, I have some questions that Dr. McRae, I'm hoping you could answer. Be able to comment, and just as you said, to get the elephant out of the room about COVID, would you be able to comment on some symptoms that you are seeing that absolutely people should come to the emergency room for those?
Probably the biggest and the symptom that worries us most is breathing trouble. And so, you know, the COVID is primarily a respiratory virus. It does cause other symptoms like GI troubles and diarrhea. But probably the most important symptom and the problem that leads people needing to be admitted to hospital is low oxygen levels and the need to be treated with additional or supplemental oxygen. And so if somebody is short of breath, and they either have COVID that's been diagnosed, or if they're having other symptoms that might be associated like with COVID, like a cough or a fever, or to be quite honest, shortness of breath of any kind that's worrying you, because we don't look for just COVID, we look for other causes of breathing trouble too. Anytime somebody is significantly short of breath, we want to see you in the emergency department so that we can test your oxygen levels, so that we can give you extra oxygen if we need to, and figure out why somebody is short of breath, and get people the care that they need. So shortness of breath is probably the big one. But also it's important to know that COVID can cause some other complications as well. It can cause blood clots in legs and lungs. It's associated with higher risk of strokes and heart attacks. And so all of the other symptoms that we would want people to come to the emergency department for, chest pain, indigestion, symptoms of a stroke like weakness on one side of your body, or trouble speaking, or trouble standing or walking, we want to see you, because we'll need to do some work to figure out what's causing your symptoms and get you the care that you need. I think you're muted, Dr. Ahmed.
Apologies. I know we're talking, it's a question from the audience. I know we're talking specifically on heart attacks, but recently this person has had 3 mid-60s female friends have had strokes. Wondered if you could comment, are these on the rise with women as they are with heart attacks? And are the symptoms similar in some cases? I'm assuming that means between women and men, but maybe you could comment on that. So just strokes in women, are there differences, women versus men?
Right. So I think overall, I'm not sure that strokes are necessarily on the rise, but I think we're doing a much better job of recognizing and diagnosing strokes quickly. Over the last 10 years or so, there really have been some remarkable advances in acute stroke care. And what that means is that we can do more for patients who have acute strokes. And that's led to a much greater emphasis on diagnosing strokes quickly. And so whenever somebody comes to the emergency department with the symptoms that could be a stroke, so weakness on one side of their body, trouble speaking, trouble understanding people, trouble with balance and coordination, I think overall we do a better job of diagnosing them. I think we're diagnosing them more often than we used to. I'm not sure that people are necessarily having them more. I think our diagnosis has just gotten better. And I'm not sure. I don't know the answer to whether men and women have different stroke symptoms. I can only speak to anecdotal experience with the stroke patients that I've cared for in the emergency department, that in general, the symptoms are the same in terms of weakness that affects one side of the body compared to the other. That's a really key point. Not necessarily weakness all over, balance problems, and trouble speaking, trouble understanding people, new visits, or new problems in vision in just one eye. So those kinds of things are the symptoms that everybody needs to be aware of, and should seek care quickly if that happens to them.
Okay, the questions are starting to come in. Dr. McRae, can you comment on how ambulance care or emergency medical services and the emergency room work together?
So the really closely and in ways that the people probably don't necessarily appreciate. I'll talk specifically about emergency cardiovascular care, and just how care can be integrated from the pre-hospital or EMS environment right up to the cardiac catheterization laboratory. And so paramedics have the ability and the training to do some on-scene cardiovascular testing. They do electrocardiograms in people's homes and in the backs of ambulances. And when they do identify a clearly obvious acute cardiac emergency, so a heart attack, for instance, they can phone ahead or contact ahead to the receiving hospital, and they'll often actually be directed straight to the cardiac center in the city. They might even bypass the closest hospital to go to the one that has the more advanced cardiac care system, so that people can get timely angiogram and angioplasty if needed, and that whole system is integrated. The paramedics can send an electrocardiogram from somebody's living room to a cardiologist's iPhone, so that by the time the ambulance arrives at the hospital, somebody with a heart attack can go straight from the back of the ambulance right up to the cardiac catheterization laboratory. So that degree of integration is really, really remarkable, and it's led to some definite improvements in outcomes for heart attack patients. We also, paramedics can patch in and call ahead to an emergency department for a variety of indications. Typically when somebody is very sick and has a low blood pressure or low oxygen levels, or they're needing advanced airway protection in the field, we usually have pretty good warning that they're going to be that they're bringing in a patient, and we know what the patient's problems are, and so in the emergency department, we're ready for them when they arrive.
So thank you for that. The next question is actually about how to prevent having to come to the emergency room, and some just dietary and lifestyle advice to avoid or slow the onset of cardiovascular disease.
Mm-hmm. I think there's a lot of great information out there that you can get either from the internet or your family doctor. I think if you're looking on the internet, look for things that are consistent and not things that are necessarily that you just saw on one particular website. But what really seems to make a difference is diets that are lower in saturated fats, lots of fruits and vegetables, and making sure that you enjoy yourself, but enjoy treats and alcohol and other substances in moderation. So if you have detailed questions, I encourage people to talk to their family doctors. Family doctors often these days have dietitians and other nutritional specialists associated with their practices. And if people already have chronic health conditions, whether it's kidney disease, heart disease, or lung disease, they may be able to access those resources through their specialists. So I encourage people to talk to their doctors about that. But I think a balanced diet that shows moderation in all aspects, and avoiding things that supply calories but not necessarily much nutritional value, is probably the best advice. But I'd encourage people to talk to their family doctor or dietitian for more detailed information.
Okay, well, thank you for that. Good advice for all of us. The next question is about someone who's unfortunately had multiple cardiac arrests in
Mhm.
a short amount of time and has an ICD right now. I'm just wondering
Mhm.
about ways to protect themselves, that, while they have an ICD, they still feel that they're higher risk.
Mhm.
If you have any advice.
Yeah, that's got to be a weight on somebody's mind. And so, for people in the audience who don't know, an ICD is a device that's implanted under the skin, with electrodes or wires that are tunneled through to the heart. So that if somebody has a cardiac arrest, this device can apply a shock to the heart and try to get the heart back into a normal functioning rhythm. And they're often put in for patients who've previously had cardiac arrests before. And so this is a really good conversation for you to have with your own cardiologist, because everybody's case is different, and there might be different medications that might be better for one patient and not for another. So I'm not going to make any specific recommendations about particular medications, but the lifestyle advice that and the general advice that I've given to try to decrease general strain on your cardiovascular system. So being exercise in moderation year round so that your body is prepared for any sudden challenges that may arise. Flu shots to decrease your cardiovascular risk from respiratory illnesses. And a diet that's going to keep your risk of coronary artery disease even lower. Then I think adhering to that kind of general advice certainly still applies to you. And so thanks for sharing that. But I think I think the answer is probably a combination of general advice that applies to anybody, and then advice that comes from your own cardiologist who knows you best.
So the next question is, a few of them have come to me by a direct message, and I encourage people to do that if you're not comfortable asking a question publicly. This person would like to know a little bit more about the area of personalized medicine. I think when I introduced you, we talked about treating the right person with the right treatment at the right time. So this person
Mhm.
just wondered, could you talk a little bit about how this information is collected and how can this be applied to a particular individual to care for
Mhm.
them specifically?
Yeah. And so personalized medicine involves, there's a lot of different ways of trying to achieve personalized care for patients, and researchers at the U of C are looking at a variety of different genetic and genomic factors that might be able to find kind of the personalized right drug for you based on your genetic makeup. What I'm talking about is using epidemiological data or data about disease patterns in thousands and thousands of people to recognize particular patterns that put people at risk. And so if you fit a particular pattern, it's saying that we shouldn't be providing one size fits all advice to patients. It's about providing advice that's as close to being relevant to you based on the way that your personal characteristics fit in with disease patterns and what we know about risk factors for certain diseases. And so being able to make personalized recommendations involves collecting data on thousands of people just like you who come to the emergency department and trying to identify patterns or personal characteristics that when we see those in the next patient, we can apply that information to you.
The next question, so thank you for that. And just to expand on what Dr. McRae was saying, that this is a huge area of research throughout the Cummings School of Medicine, definitely within the Living Cardiovascular Institute.
Mm.
So thank you for your interest in that. The next question is about someone who has in the past been diagnosed with heart failure and experiences shortness of breath, and feels that this might be because of some undertreatment at times, also has a number of cardiovascular conditions. And so if this person has chronic shortness of breath, they wondered if there are ways to differentiate between their regular symptoms and something that might be more serious, that would indicate a reason to go to the emergency room. And do you have any specific suggestions for this person?
I think, thanks for sharing that. I think probably the first question I'd ask is are you experiencing anything else besides the shortness of breath? And so are things like, are your legs swelling any more than usual? Has your weight changed if you're monitoring your weight? Has there been anything else different going on in your life? Like have your medications changed recently that may lead to a symptom change? Or are you experiencing anything else like chest pain? Are you feeling lightheaded when you stand up? So trying to see, are there any other associated symptoms that might be red flags or warning signs of something more serious? And then, is it just your best guess? Well, your best guess is probably pretty good because if you've been living this for a while. And so I think the thing to think about is rather than the quality of or the intensity of the shortness of breath, is the change sudden? has it happened, just in the last day or in the last few days? Or have you been noticing that over the last few weeks to months, it's easier to tell if something is new and dangerous if it's sudden. And so focus, I think talking about or being aware of the timing of the change in your symptoms, and whether it's associated with many of the other danger symptoms that we talked about. But your intuition is probably pretty good. And so if you're worried, come and see us.
A question about, are you seeing more COVID cases, or I should say people with COVID, in the emergency room compared to cardiac concerns? Or have you noticed,
Mhm.
and maybe I'll just paraphrase, have you noticed a shift in terms of the concerns that bring people to the emergency room? And how has that been influenced by COVID?
Yeah, we certainly did, especially early on in the pandemic, like through March and April. We definitely saw a decrease in, we saw so few cardiac cases that we actually were quite worried that people were dying at home because they weren't coming to the emergency department. And so actually one of a medical student who works with me has done a research project and analysis looking at differences in what's happened in EMS calls over the course of the pandemic, and actually saw a threefold increase in out of hospital deaths in the early phase of the pandemic. And part of that's probably attributable to the opioid pandemic, but we do worry that people have been staying home with serious heart problems rather than coming to the emergency department and seeking care. We saw a decrease in other problems like major trauma because people were going out and driving less, because people were not going out and using substances as much. But we also, at the same time, we saw an increase in both accidental and intentional overdoses. And so there certainly has been a change, especially early on. Over the summer, emergency department volumes in our case mix got pretty much back to normal. And what I'd say is happening right now is that we are still seeing our usual volume in case mix, but we're also seeing COVID cases, and the steps that we're needing to take to keep people safe, and also the effect that COVID is having on ICU capacity and capacity in the rest of the hospital, and the need to delay scheduled surgeries and that kind of thing. That COVID is making it even harder for us to provide good care in the emergency department and the whole hospital right now.
Okay. Um, Thank you for that. And I'm really appreciate you speaking about COVID, because I think that is on a lot of people's minds right now.
Mhm.
Uh, and just before I move on to the next question, just wanted to highlight, you probably saw across the screen, there was a virus warning. Everything seems okay. So there hasn't been a Zoom breach or anything like that. So not to worry anyone. And next question is just about losartan, which for those people who may not be familiar with it, it's a blood pressure medication, an angiotensin receptor blocker, and commonly used for lowering blood pressure. And so there's a question about, is this safe to take, as I had not heard this, airplane fuel in it, at one time being made in China. Um, I'm not sure I can comment on that. I prescribe that medication, or that class of medication, quite a bit. Um, Dr. McRae, I don't know if you have anything to add to that. But
No, and it's not a medication that we use often in the emergency department because it's a treatment for chronic high blood pressure, but it's not something that I had heard of. So that's at least two of us, and this is the first we've heard of it.
I would also just like
Yeah.
to say, not is, if somebody is on a medication, please speak to your physician before you stop taking it.
Yes,
Just because the
good point.
consequences of suddenly stopping it, it could be a reason that you may have to go to the emergency room and see our
Yeah.
colleague, Dr. McRae. So just that's a tip. Next question is just, this is a person who has a mechanical aortic valve. So for those who may not be familiar with that, that's a valve that this person has undergone surgery and has been replaced with a mechanical valve to replace their own tissue. Um, so this person had heart surgery at the age of 45 and is now at age 60 has had an ICD, which we talked about that before, an implantable cardiac device. Uh, what are your recommendations about this person taking aspirin if they require chest pain, if they have chest pain? Should they be taking it before they go to the emergency room, or should they wait till they get to the emergency room? What are your thoughts, Dr. McRae?
So for people who just for the rest of the audience, aspirin is a good medication for reducing your overall cardiac risk in the long term, but it's also one of the treatments that's been shown to decrease the risk of death in patients who have confirmed heart attacks. And so um, it's a single dose, and I gather the reason that you're worried about taking aspirin is that you're probably also on another blood thinner because of your mechanical heart valve. Is there a risk of mixing the aspirin with the other blood thinner that you're on? And in a single dose that you would take after experiencing chest pain, then aspirin is probably absolutely safe. That single dose of aspirin. Um, if it turns out that you're not having a heart attack, and 85% of people who come to the emergency department with chest pain, we ultimately end up figuring out that okay, it wasn't a heart attack. So it might be safe for you to avoid it until the diagnosis is confirmed. But if you are having a heart attack, and you certainly are someone who is probably at risk of cardiovascular disease, taking it early is not going to hurt you. And so my advice would be to err on the side of taking it early. Profile. If it were a young person who didn't have any cardiovascular risk factors, who suddenly had chest pain, I'd say, okay, maybe you could probably wait to take the aspirin until we're sure that it's a heart attack or not. But for somebody who has known heart disease, I think probably err on the side of taking the aspirin rather than waiting.
Mhm. Um, so thank you for that. And just this is a question that's come through. You had commented on the role of stress and being increased over the holiday season. And so wondered if a person can't necessarily address the underlying cause of the stress, but do you have any suggestions for small things that could help a person, just reduce their anxiety?
Mhm.
Again, if they have concerns, they should go to the emergency room. But just
Mhm.
wondered if you had any suggestions of things people can do at home.
Yeah. Um, I think people need to talk about the fact that they're feeling stressed and why they're feeling stressed. I think especially around the holiday season, we create expectations for ourselves. There are traditions that people want to adhere to, and that as much as tradition and that kind of thing can be a comfort to us, they can also create some stress for people and create expectations. And so I think it's just important, if you're feeling stressed out and overwhelmed, talk to your loved ones. And if you need to reach out to somebody outside of your family to talk to, please do that. Reach out to your family doctor. Reach out to the distress line. In Alberta, in Calgary, there's a line called Access Mental Health. That's a one-stop referral service for people who need to talk to somebody about what they're feeling. And that's probably the biggest thing, because just that simple act of actually talking about it often makes people feel better. And if it doesn't make you feel better, at least you have somebody else to troubleshoot problems with. And so I'm no stranger to stress in my professional life, and that's really the thing that works the best, is to talk your stress through.
Mhm. That's excellent advice. That there is a lot of stress because of the holidays, as is usual for this time of year, and certainly there's increased stress with the pandemic. So that's excellent advice for all of us. So with that, actually, I will bring the evening to a close. And we have one more question that's just come in. Um, can you comment? Do we have adequate numbers of cardiac emergency room physicians in Calgary?
Um, So within the city of Calgary at our 4 adult hospitals, there's about 200 emergency medicine specialists working there. And so our staff situation.
I think you're freezing on us, Dr. McRae. I don't think we can hear you right now.
Is quite good. You know, I'm and they're only
Okay, looks like we might have lost Dr. McRae. So that's, but what I can tell you as a non-emergency room physician, that we feel very adequately equipped and very well supported by our emergency room colleagues. And that I can assure you that we do have an adequate number. We are also very fortunate of not also just having physicians who provide healthcare, but actually, like Dr. McRae, do research and are looking to how can we make the experience, how can we make outcomes, how can we improve health even more. So with that, because it looks like we've really lost Dr. McRae, is that we will bring the evening to a close. I want to thank every single person for giving us your time. We know that's one of everyone's most valuable resources right now. And so we really appreciate that you chose to come spend it with us. I will thank Dr. McRae when he comes back or later for his time. I think we all learned quite a bit today, and I really want to reinforce his message that if you're worried, come to the emergency room. We are open, the hospitals are open, we are here to help. So just last thing, we don't want to lose the momentum we've created around women's cardiovascular health. If you'd like to be directly involved with CV and me, please reach out to us via email. If you'd like more information, if you'd like to donate to support this research, to any of the programs in the Libin Cardiovascular Institute and CV and me in particular, please contact Myrna Linder at mlinder@ucalgary.ca. You will receive that via email later. And lastly, your feedback is incredibly important to us. So if we sincerely appreciate it if you'd complete our short survey to give us some feedback, let us know what topics you're interested in, because we are truly here for the public and for the community. And how can we make this public lecture series even better? So a link will be sent directly to your email that you use to register after this session, or you can email us at at ucalgary.ca if you have any specific questions. And also follow us on Twitter, Facebook, or subscribe to our newsletter if you want to know more about our upcoming events. So with that, I thank you very much. I wish you all a safe and happy holiday. Be well. And as I said, be safe. Thank you again. Okay, bye-bye.